Morning, everyone. Welcome to Pediatric Grand Rounds, the 25th of January. Today we have Ms. Angela Alderman speaking to us. Angela graduated from Radford with a PSN, worked at Children's Hospital of the King's Daughters in the team for many years prior to joining Carilion in 2006. She is currently a team lead in the NICU and the chair of the Central Line Access Committee. She has done numerous QI projects focusing on vascular access, maintenance, and quality care, and is here to educate us all. Please welcome Ms. Angela Alderman.
Thank you, everybody. I'm excited to be here. We want to talk about venous depletion in pediatric patients this morning and what that means for our children's hospital. And so, fortunately, I have no relevant financial relationships. I have nothing to disclose, and we're not going to talk about anything that's off-label. So the objectives for today are to be able to identify what impacts our capacity to gain IV access in our pediatric patients. And as you well know, that's pretty hard to do sometimes. We want to discuss what vein depletion means for this patient population, the long-term effects of vein depletion in pediatric patients, which is mainly what I've focused on in the last several months, and then to recognize algorithms and processes that will decrease this vein depletion, as well as be able to increase our first stick success rates. And then we want to identify different types of IV catheter devices and what catheter is appropriate for what length or duration of therapy and treatment intended. So really, how confident are we in our vein structure? This person has great veins. I would love to be able to say that all of our pediatric patients have such great vascular access, but they do not. And so what we need to talk about is really what lies beneath. And when we look at those things, you know, children can, on the outside, look like they have great vasculature, but on the inside, there's a whole different story. And so, you know, where are the valves in their vasculature? Do they have sclerosed vessels from repeated attempts? Do we have collapsed veins? Because as you well know, not all of our children come into our hospital healthy. They're here for a reason. We have veins that are scarred down. And typically, when we have multiple venous access problems in children, we talk about DVT later on in their life and sometimes even in their young life. And then we have the potential for a lot of endothelial injury. And so we look at all of these things when we're trying to gain access to those patients. So it may look good on the outside, but on the inside we have a lot to worry about. So there's an illustration of normal venous anatomy, and it is to the right, my left, obviously. But we look at that and we think, oh, that looks so nice. It does have a valve in there to kind of give you some anatomy, but what impacts our capacity to gain IV access? So most of our patients who come into the children's hospital are super sick. And the one thing that they get when they come here is an IV, which is quite painful. But they are not well hydrated. They're normally hypovolemic. There are some children that have obesity issues, and so overweight individuals tend to have a harder time to gain IV access. And then their extremities tend to fold, and so talk about hemostasis. Their skin tone makes a huge difference. So darker toned skin children are harder to gain IV access because of the visual inability that we have. And the two populations that significantly are known to have IV access children are the extreme elderly and obviously the pediatric population, including neonatal ICU. And so what impact does that have on repeated catheter insertion to these vessels? And so you have a risk of infection and contamination. If you're sticking a child and you have punctured this child's skin several times over, And we talk about this in neonatal ICU because we have such an immune-compromised population of patients. You're increasing the risk for infection. We talk about tissue trauma, both superficial and deep tissue trauma. Repeated sticks causes a lot of tissue trauma, and you see lots of bruising. Sometimes we get skin tears, especially in our smaller babies. Mechanical injury from catheter tips, and so because we can't visualize where this catheter tip is going, sometimes we'll be up against the wall of the vessel and cause injury. It can cause, endothelial injury from being too close to a valve, or, if that child does have a scarred down vein and you're up against that part of the vasculature, you can cause a lot of injury. And then shear force injury due to high flushing velocity. The Avatar group in Australia has a pretty remarkable scoping study that is ongoing. And I learned at the Association for Vascular Access Conference that they have this beautiful ultrasound machine that they're studying, intravascular depletion for all patient populations. But they had this remarkable ultrasound video that they showed where the velocity of flushing actually can cause the catheter to smack against the endothelial wall and break it off inside the vessel and cause a huge amount of trauma to the vessel, as well as a lot of injury to increase the risk of their thrombosis and occlusion of that catheter. And so we need to be careful when we're flushing IVs that we're just not pushing as much as we can as fast as we can. And then we talk about infiltration and extravasation from therapeutic drug administration. We give a lot of medications to these patients, and some of them are, they're not well received by small vessels. They need to be in a more central catheter so that they're more diluted because they're pretty caustic. And when we talk about neonatal ICU, because that's where I'm from, we look at their vessels and they're extremely fragile. And when you're putting several infusions in there that are pretty toxic, if not diluted, it requires a bigger vessel, and pressors are one of those things that we give a lot of. And then we talk about hypercoagulation, which sometimes we see. And so that's your dehydrated patients or your ABO patients or children that have a coagulopathy. And so we worry about having access for those patients. So what really happens with endothelial injury, which is the main concentration of depletion, is that you get an initial vasoconstriction of the vein as a reflex response. When you are inserting a catheter into the vessel, your body has a response to kind of vasoconstrict that part of the vessel as a protective mechanism. Then you have what's called primary hemostasis with platelet adhesion to the area. In addition to that, over time, you have a secondary hemostasis with a possible formation of a fibrin clot, which leads us to the formation, eventually a thrombus formation, because it decreases blood flow to that area of the vessel. And so we talk about inflammation to that part of the vessel, and if you think about catheters that stay in a prolonged period of time, we wonder why we have catheter occlusion. And so, sure. And so this is what leads to inflammation to that area, further tissue damage, and then sometimes we'll get thrombophlebitis. And so we have to think about these things when we are repeatedly sticking patients. And so most of this process can happen over a period of time so that you have an occlusion of a catheter, whether that be a central venous catheter or a peripheral IV. But what we worry about is that when you're sticking the vessel, every time you stick the vessel, that you are giving this child the potential of scarring their vessel down in that particular place for the rest of their life. So what's the big deal? This picture was taken at a conference. This child had a heart defect, a congenital heart defect, so that's why you see all the lovely stitching. But the point to note about this is that we're looking at the SVC, that's what my big green arrow is, and there is a huge clot in the SVC of this patient. The only thing that travels through this clot would be the catheter that was placed for treatment, for therapy for this patient. And this clot, it extends like a pretty far distance, almost down to the cavioatrial junction. And so when they took this catheter out, it was pretty impressive to see this thrombus. And so those are the things that we worry about when we're talking about venous depletion, is where our catheters are, how many times we've stuck this patient, and obviously scarring down very important vessels that they need lifelong. So we talk about the effects of venous depletion in pediatrics. So it increases, obviously, the risk of infection, which I've said before. It's painful and traumatic. I can't imagine having a child in the hospital, and we've stuck this child 8 times, and we're going to stick it probably 8 more times. And depending on the duration of therapy, their child could have up to 32 IV pokes in one stay in the hospital. It's a delay in treatment. And so if you have a child that's really septic and you're having venous access issues, you get that delay in treatment. You know, we always talk about the golden hour, especially for true sepsis patients, and it might take you an hour just to get vascular access. It increases their morbidity and mortality. I mean, we see a lot of congenital heart defect patients that need a multitude of lines, and they have a multitude of horrible vascular access. And so we're seeing now intrahepatic catheters that are being placed by IR because these children have no vasculature left. So it increases their risk of DVT later on in life. And that can sometimes be up to 3 to 4 times. I mean, I know premature babies specifically have a 3 times greater risk of deep vein thrombosis later on in life just because of the multiple IV access attempts that they have during their stay in the NICU. And so the younger in gestational age they are, the more IV access issues we tend to have with them. And so there was a study published not too long ago in 2016 that stated that for neonatal ICU, that those patients have an increased risk for DVT, and that their DVT would probably show up between the ages of 1 and 5 or 18 to 32, is what the study said. And then we have, obviously, an increase in surgical line placement, which leads to vascular access complications. And so we try to stay away from surgical lines. So the sheer picture that I just showed you, which was a surgical line that was placed in the SVC, because we only have one set of vasculature to us. And preserving that is pretty important. And 85% of thrombosis that are significant to children are with central venous catheters. We have an interruption in nursing workflow, and I know that sounds silly, but when you're spending tons of time just trying to gain IV access on one patient, that takes a lot of time, and you want to devote time, obviously, to all your patients. And so it's a true interruption and delay of care for other patients sometimes when you're having vascular access issues. And then it increases our length of stay. And if you look at my word stay, there's a $sign there. That's huge. We don't want to keep our patients here in the hospital longer than they need to be. But if we're having vascular access issues, we're delaying their care, it's going to keep them here several more days. And especially if they get an infection from our repeated attempts, they're going to be here longer. And then, obviously, it decreases patient satisfaction scores. We want people to remember that we healed their children and that we do good work here. We don't want them to remember the 32 sticks that their child received in our hospital, and that's the only thing that they have to say about us. So now what do? We need to look at what we all can do to prevent the 22 sticks from happening in our most vulnerable patients. And so I didn't just get the 22 sticks out of anywhere. I was called recently to put a central line in a 5-month-old, and this child received 22 IV sticks prior to me getting there to put this line in. And that's really not okay. We need to hold others accountable, and we need to think about our goals of therapy. You know, I've been called to put lines in patients, and I go down to start an IV, and it's a 2-year-old, and they're very sad, and they've been stuck to death, and then I show up, and I'm like, okay. And then I stick twice. I really sit back and look. I say, okay, well, why does this child need this IV? And I go to the provider, and I'm like, do we need this IV? What's the goal of therapy? What are we doing? Oh, no, we just wanted it for an emergency. And so that's a big problem. So we really need to look at what the goal is. And we want the right clinician for the right patient at the right time for the right sign. And so we talk about having special teams. If anybody knows me, my husband played for the University of Tennessee, so that's why I have a UT picture up here. Go Vols. And so we talk about special teams. They have special teams in sports. We have special teams around the hospital that do lots of different things. And so the important thing is that we have a special team here in our children's hospital for vascular access. And so we are trying to have a formation of a vascular access team here at the Children's Hospital. And so what this will do for us is to develop and foster an interdisciplinary team approach to IV therapy. It will create a systems approach for difficult vascular access cases so that we're just not picking people to stick our children. It decreases the number of insertion attempts overall, which I think is fabulous. We want to increase our patient satisfaction. We don't want children to be sad when they come to our hospital because they know they're going to get stuck multiple times, because prior to that, when they've been to us before, they've had difficult vascular access. We want to decrease the need for surgical line placement. And we're not saying that patients don't need surgical lines. But when it comes down to it, what we're doing is we're wasting all their vasculature, and then we have no other choice but to ask the surgeons to come in and do cut downs and really scar children and have a really traumatic experience for them, because now they have to have a surgical line because they didn't gain any other IV access for them. But the goal is to save the vasculature of pediatric patients because they're little and they haven't lived a really full life. And so by the time they're 80 years old, do we really want them to have difficulty, especially? I think of those people who need dialysis. And so, you know, if we're utilizing all of our resources here now, we may be saving their vasculature for later when they truly need it. And then coordinating evidence-based practice throughout the Children's Hospital, especially in vascular access, and ultimately to decrease our bloodstream infections, complications, and obviously the huge amount of cost that CLAPSIs, as you well know, is a problem. So keep calm and be a diva. So this is the Diva scoring tool. This is something that we hope to roll out within the next year. The Diva scoring tool came from Cincinnati Children's Hospital. They developed this tool to kind of gain an appreciation for who qualifies for difficult vascular access. And so it has a predictability variable that if you have a score that's higher or equal to 4, you are 50% likely to have a first failed attempt for these patients. There is a Diva scoring tool that accounts for prematurity. This one doesn't necessarily show that, but they have added that in a supplement. And so you would look at your patient on admission for the pediatric population and decide whether this patient has a history and or has difficult vascular access. And this tool should guide us in who sticks this patient. And so this is a peripheral IV insertion algorithm and I know it's difficult to see, so I'll try to make it really short. It essentially assesses the access of the patient and then proceeds. So looking at this, in either algorithm path that you take, it limits this patient to maybe 5 sticks, maybe. And so it talks about who should be sticking this patient. And so you look at if the child has known difficult vascular access, their mom or dad comes in, aunt, uncle, grandparent, and says, you know, Lucy was here, she was here last month, you all stuck her so many times, we had to have an important team of people come and stick her. They would be already known to us as difficult vascular access. And so she would go down the path on the left-hand side that we would talk to the providers and decide what best treatment would be for her and her vascular access. Should we go ahead and call the vascular access team? What's her duration of therapy? What kind of line do we need to use? Or should we, if she didn't need vascular access but just needed an experienced nurse or provider to stick her, then they would have a 2-limit stick by an experienced person. Then we talk about the third stick being by guided ultrasound, and I'll talk more about that in a minute. And then we would call vascular access team. And that's how this algorithm works. We may tweak it for our children's hospitals, depending on. So then the not difficult or unknown patient that comes in, either through the emergency department or a direct admit, that patient, we would utilize the Diva scoring tool by doing an assessment of their vasculature and really utilizing that tool to decide, okay, do I think this patient's going to be an easy stick or is it not? And so if we think that it is, we'll get an experienced person in IV access to stick them twice. If they are not able to obtain IV access, then the third stick would be with ultrasound, and then we would call the vascular access team. And the other part of this is that if they're not known to be difficult, if it's a patient that we think would be successful and their Diva score is low, then the first stick can be by a novice person. And so that would be maybe a newer nurse that needs to hone in on their IV access skills, maybe a medical student or resident that's trying to gain some practice in vascular access. And so those would be the children that I would recommend that you could try an experienced person to stick them. And then if they don't get it with one attempt, then you would call someone that was an experienced provider in vascular access, and they would have to stick attempt, and then it would obviously go to the ultrasound and then vascular access team. So let's have some magic. So the Magic in Michigan study stands for the Michigan Appropriateness Guide for Intravenous Catheters. That's a long title. But they found out in Michigan, and they did a really great study, that people were putting all kinds of different lines in all kinds of different patient populations, and it was just like picking a line out of a hat. And so they made a really good decision-making tool as to what line really is appropriate for what duration of therapy for patients. And so it validated a method for developing the indications for multiple catheters because we have lots of choices. And then it improves patient care and it advances the safety of our patients when we talk about CLABSI rates. And so they also define several indications for insertion and maintenance and care of PICC lines because that's what we're having problems with. So we'll go back to this chart. So if you look, if your patient has less than 5 days of therapy, peripheral IVs and ultrasound-guided PIVs are pretty good for that duration of therapy. They're kind of sketchy, so if you look at the little bar lines, it's kind of neutral recommendation to last up to 14 days, and most likely in pediatric patients. If you get a peripheral IV that lasts up to 14 days, I want to see it. And so then we talk about midline and non-tunneled central venous catheters. But if you look, PICC lines are really indicated for therapy that goes past the 5-day mark forward. And so we try to stay away from surgical line placement due to the risk of venous thrombosis. And so PICC lines are really what we utilize most, I think, in our pediatric patients, other than our chemo patients that will sometimes need ports because their duration of therapy is much longer. And so this card has been very helpful to other hospital facilities and other children's hospitals in deciding which line is right for your patient. And so what is our goal? This poor child, he's been through it. So for peripheral IV catheters, our goal is to increase our first stick success rate. So how do we do that? We want ultrasound guided peripheral IV placement for all children. That is the wave of vascular access future for pediatric patients. We want to utilize a comfort promise to families. And so that promise is that we are going to do everything that we can to increase our first success stick rate. And we're going to provide comfort and pain relief to those patients that come into our hospital that need vascular access. We want to use resources such as child life. And that's a huge piece in children, is having someone be able to distract a child so that they are less likely to jerk their arm, leg, whatever you're trying to stick, so that we have better success in getting their IV the one time. And to join a national collaborative to gain knowledge and educate. So there's a national collaborative for using ultrasound-guided peripheral insertion called the 1 Million Pokes campaign. And so they're just the inception of this program, but it is pretty inventive, and they're looking at really a lot of facets on how to gain first success in children. And then we want to decrease the fear in children that come to our facility, because when anybody's entering into the hospital, they go, oh my goodness, they're going to poke me. I mean, think about it. When you're a little person and you know that you come to this building and the first thing they're going to do is start wrapping a tourniquet around your arm to look for what you got left, it's pretty fearful. Not only for children, but their families. So for central venous catheters, we want to decrease the overuse of central lines in pediatric patients, and I know there's been a lot of focus on this due to CLABSI and having central line infection rates for a national standard. But there's also, we want to decrease vessel thrombosis associated with central venous catheters, and so we know that 85% of thrombosis for pediatric patients comes from central venous catheters, no matter if it's a PICC line or a surgical line. Obviously, we don't want CLABSIs in our hospital. We always have that goal. We want to increase our knowledge on alternatives. And so what I mean by alternatives is like extended dwell catheters. They're not midlines. They're just they're extended dwell PIV catheters, and they're fairly newer on the market. There is a Brigham Women's Children's Hospital in their neonatal ICU. They can get away with putting 2 lines in their patients, and we're talking like 23-week patients. And so they get away with it because, number one, they put a PICC line in very early on in that child's life for IV nutrition and all of their IV therapies. And then they put an extended dwell catheter in so that they can have access for blood transfusions for these patients. Because if you know anything about premature infants, they require quite a bit of blood transfusions early on, especially lower in their gestation range. We're talking about our 23, 24, 25 weekers. And so they get multiple IV insertions sometimes due to blood transfusions. And so at Brigham Women's, they've decreased their amount of sticks in their patients by putting this extended dwell catheter in, as well as a PICC line, so that they have those 2 paths of IV access so that they are decreasing the number of sticks overall to their neonatal ICU patients. And then incorporating special teams. And so those special teams, the vascular access team that we're hoping to form for the Children's Hospital, can be pretty valuable. And it's been shown that teams have more success, not only in IV access, but in thinking of different ways to treat different IV access problems in patients, and also decreasing central line infection rates, having better compliance, and being able to save vessels overall, especially some pretty large vessels that we need later on in life. And we want to change the process. So ultrasound, what it can do for you. It's been known to have a faster time to cannulation of vessels. There's seriously fewer number of punctures, and obviously there's better success rates for first attempt. And so there was a talk that was done on ultrasound-guided peripheral IV insertion, as we talked about earlier, and there is a learning curve. So teaching a clinician to use ultrasound for peripheral IV insertion is not that bad. And the learning curve is short, so it is possible for people to learn very quickly how to do that. And so hopefully we will be moving toward peripheral IV insertion by ultrasound for all of our pediatric patients. And lastly, to be the power of one. To educate every healthcare provider that comes in contact with a vascular access device. So knowing really what we have available, what vascular access devices we should be choosing, and to be very educated in the realm of vascular access, especially when you're asking for those things for your patients. To choose the right clinician to insert the right line for the right patient at the right time. And so we would not want an inexperienced nurse to insert a PICC line in a congenital heart defect patient. And so making sure that you know the key people that are in the Children's Hospital that can gain IV access in your most difficult patients. Changing policy and process to reflect our goals of care. And so we want to decrease the amount of puncture sticks in the Children's Hospital overall. And so being able to have that ability would be so awesome for our Children's Hospital. And then taking the data that we have to support and drive our decision-making in vascular access. And so seeing what ultrasound can do for the Children's Hospital, how many pokes that we can decrease here, how much happier our families will be, and looking at our decreased length of stay as well as our decreased infection rates. And then finally, to educate patients and families in their vascular access devices. I can't tell you how many times I've gone to moms in the NICU and said, okay, we put this PICC line in, so what does that mean for you? It means better hand washing, making sure that when you're changing the diaper, that you're not touching anything that has to do with that central line. If you see this dressing coming loose, please tell someone. And making sure that they know that they can be a part of our team and advocating for their own infant. When you get your baby out of bed, make sure we're not pulling on this line because it's not sutured in and it will come out. And so empowering those families and those patients to know how important their central lines are and how important their vascular access is, so that, you know, if I say to this mom, you know, it really took a very long time and a lot of effort to put this in, and we don't want to lose this line because I would hate to have to come back and stick your baby. That's important for families to know, because some families are not here all the time. We have moms and dads that have to go back to work, so if they're coming in for a visit on the weekend and they haven't had an opportunity to be here for 3 or 4 days, letting them know, hey, this was a big problem. Then they're more careful when they're getting their infants in and out of the bed. They're more careful with the handling of that child's central line, and they will speak up when there's a problem. And then special teams, creating and utilizing special teams within the Children's Hospital for vascular access will make a huge impact on our patient population. So be sure to put your feet in the right place and then stand firm. Thank you so much. Have any questions?
Anybody have any questions in the room? All right, hang on, I can unmute the phones. Make sure. Over here, drag the cord. All right, if you're on the line and you do not want to make a comment or ask a question, just please put your phone on mute now.
The conference is now in talk mode.
Does anyone on the line have any questions for Angela?
Yeah, I was curious, what is different about the extended dwell catheters that allows them to be left in longer as opposed to the standard peripheral IV catheters?
So the extended dwell catheter can last up to 29 days. It's the length of the catheter and where it is placed that it has the ability to have a longer time frame in the vessel.
Do we have these available at Carilion Children's right now?
We do not.
Okay. And what locations can you place these as opposed to standard peripherals?
So it's recommended that they be placed in the forearm.
Mm-hmm. How long is the catheter?
It depends on the patient's size. They can be anywhere from 3 to 8 centimeters in length, depending on the size of your patient. And so in the NICU, we would use the smaller extended dwell, and then obviously in your older pediatric patients, you could go up. They do come in a variety of sizes for our pediatric patient population. So depending on the size and weight of the child is depending on what length of catheter you would use.
Okay.
All right, we got a question in the back. Hang on a second.
So with the things like the extended dwell catheters, you know, one of the things is, I mean, sometimes we'll have a functional IV that was placed for blood products. The kid's a feeder grower. We don't foresee a need kind of coming up. So when is the decision made to say, hey, this kid's, you know, early on they're needing transfusions kind of, you know, every few-ish days and stuff, but you get to the point where that's like, okay, yeah, they're going to need one sometime in the future, but it's a very unforeseeable time frame and a longer time frame, and leaving anything in the body is a potential infection risk. So where does that
play into therapy? So Brigham Women's, they would discontinue their extended dwell catheters when either their PICC lines were getting ready to be DC'd, so their IV therapy altogether was being discontinued, or they felt like that the child was doing clinically well and was not going to require multiple transfusions within the next 3 weeks.
Any other questions on the phone or in the room?
Yes. Hi, this is Fran Conklin from Centra and Lynchburg General. Hi, Angela. Thank you for your program.
Hey, Fran.
Hey, I wanted to give a little bit more update on these extended dwells because they're fairly new or a reoccurrence of them. But one of the great things is that the material that they're made out of is a little nicer to your vessels than the conventional angiocaths are. It's a softer, flexible thing, and they're usually put in with ultrasound, which means there's less trauma to the vessel as a general rule. But the other thing is you have more catheter that gets into the vessel, so that's another aspect that extends the life of the catheter. And it's all about how long that this patient's going to need IV access. If you have someone that needs 7 to 10 days, it's a great choice initially, especially in your pediatric population. We're just getting ready to do a trial here with our adults, and I'm hoping that it's going to decrease the number of attempts that our patients have to have.
Thank you, Fran.
You're welcome.
Any other questions on the line or in the room? I thought I saw a question up here. Hang on a second. You got to wait for the mic.
Subcutaneous boluses, the role in that and the assistance to help with Diva scores and first try access?
So sub-Q boluses cause tissue trauma and can cause underlying vessel trauma depending on where you're administering them. And so I can't really speak. I don't have a lot of experience with sub-Q boluses as a standard. I mean, we want to decrease the number of pokes that we give children overall, but we don't want to cause any more tissue trauma than we have to. And obviously, if the goal of therapy, because your patient's hypovolemic and you're wanting to give boluses, you know, it just depends on, is this patient going to need an IV for just a bolus, or is it going to need an IV because this patient is really sick and it's going to need long-term IV therapy?
I don't know if anyone is from Centra still on the line.
I am. Yeah, we do use it, but it's not for that septic patient. It's for that mildly dehydrated patient, like the really pudgy patients that once they get dehydrated, it's kind of challenging to find an IV access. So rather than sticking them multiple times, but you need the drug, the Holodecks, which opens up the pathway to let that fluid be absorbed. And without that, like Angela said, you do just get the hardness and everything. This is a revamped thing from the 70s, and we have a better drug now that we can use, and you have less irritation from it. It's not for every patient, but it sometimes gives you a bridge until you can find better access. And we've had several patients that have been challenged, have a history of it, and their parents have had the subcutaneous hydration. And when the doctor said, well, go ahead and get IV access on them, the mom said, what for? You know, they don't need any other drug. They just needed the IV fluid. And we've managed a day or two of just subcutaneous hydration. But those patients are few and far between. It's not for your septic patients, those patients who need IV antibiotics. So you are limited to who you can use it on.
And you all have been using that for a couple of years now?
A couple of years. Well, I have to tell you, I was using it in the 70s. And then, and then it went out of vogue, and then because the hyaluronidase went off the market for a while there. But this is a recumbent hyaluronidase, and it's pretty sweet. And I've taken it to the adult floors when you have the very elderly patients that come in from the nursing facilities and who there is no IV access available. And it works great on those patients. It gives them a bridge for the family to make decisions. So
we're not doing that here, correct, right now, Angela? That's what I thought. Okay. Any other questions or comments? All right.
I would comment on that subcutaneous.
Oh, go ahead on the line.
Okay, thanks. Hey. On the subcutaneous rehydration, this is Hannah Smith. I'm currently working in pediatric hemonc, and I had started some work on that a couple of years ago to try and make it an option for Carilion children's. And then because of transferring departments, that just kind of got dropped. But whoever it was in the room that asked the question, I have a great deal of research on it. I have a policy written up in Carilion format that could be used if that's something we're interested in making an option for those few patients where it is very appropriate. I do have a lot of work already done. I just need someone who's working in an area where it would be used to kind of pick up the project and go. So if you wanted to contact me about that, I would love to talk about it.
Okay, and that's Hannah, right?
Hannah Smith, yes.
Hannah Smith.
And peds oncology.
I heard one more person on the line who had a question.
Yes, Alex. This is Dr. Olasagasi, Dr. O, PTI. Just to make a comment, if we have an established IV team, it's very important for our residents to have a chance to, an opportunity to practice and get some skills with IV start. I know that most of the IV teams are called, you know, at a certain point when there is a failure of some IVs starting. But for the skills of our residents, it's very important to keep that in mind. Again, I don't know what is in place right now for them, but as a resident way back, you know, I remember how important after the fact, you know, once you graduate, if you work in certain as a hospitalist or if you work on a small hospital, things are very important for them to have some feeling that they know how to start an IV on a baby without the anxiety of failure. That's just a comment again. But
thank you, Dr.
Thank you.
A question from Tanya here. Hang on.
Hey, Angela. Thank you for your talk. Just wanted to ask a question about the vascular access team. Where are you pulling your experts from?
So for vascular access team, and it's fairly new, we've started a committee. So the Children's Hospital started a committee a couple months ago, and our resources that we have are, I have people from the hospital-wide PICC team that are interested in pediatric vascular access. So Jessica Gussler from our house-wide PICC team is specifically good with children, and she wants to learn more about younger children for vascular access. So I kind of plucked her out of the house-wide PICC team to serve on our committee. We have physician representatives from surgery as well as the directors from PEDS, PICU, and NICU. And we've asked for representatives from each department. So like the PEDS emergency department we've reached out to see who is good at vascular access. And so the people that we've asked to come to the committee are people that are known good vascular access people on the floor. So the frontline nurses that if you were working on the floor with them and they said, okay, we've got this really difficult patient that needs an IV, who do I call? And so they've designated nurses that are really good at IV starts and IV access to try to be on the committee, to have a voice on the committee. And so that's where I've tried to start. And so the committee will be meeting again in February to try to make some decisions based on that.
One more question. Do you have a question?
For neonates, is there a move away from umbilical lines to PICC lines, or did you just not include that because that's such a limited group?
It's such a limited group. I always tend to talk neonatal ICU because that's my strong suit. But I wanted to cover general peds, so that's why I didn't talk about it. But yes, utilizing umbilical venous catheters, especially in our 23-weekers when their veins are so small, is super important because the study that was done by Griffith University said that a catheter should not be any more than 30% of the total intraluminal diameter. And so if you look at our itty-bitty patients in the NICU who weigh like 400 grams, that's pretty impossible sometimes with the size of our catheters that are really so small, but they're really too big. And so, no, I didn't.
Anyone else on the line or in the room have a question or want to make a comment?
Alex, this is Dr. O one more time.
Go ahead, Dr. O.
Angela, I just want to thank you for all the resources that you have provided us in our pediatric floor and all the help that you've given us through these years. I just want to thank you very much.
Oh, thank you so much.
Sounds like a good way to wrap it up. All right. Thank you all very much.
Thank you.